So thanks so much for joining. Just to kind of get started, we have some really great industry experts talking about remote patient monitoring today. Joining us from Continua, Chronica, and Huku. So with that, let's just do some quick introductions. Jeff, you want to introduce yourself real quick?
Sure. Hey, everybody. My name is Jeff. I've been in the remote patient monitoring space for over 10 years now. I started a company called Optimize Health, which is now called Vivo Care. Scaled that to tens of thousands of active patients. And recently, I've been focusing on artificial intelligence. And then at Continua, we do connected devices for RPM companies. I've been in health tech for about 15 years now. I've taken multiple companies 0 to 1. And, I still love remote patient monitoring and I enjoy helping people think how to design their programs.
Great, thanks, Jeff. Tom?
Yes, hello everyone. Great to be here. I'm a serial entrepreneur. Most recently, built a cloud platform for value-based care, served about 15,000 physicians. Since exiting the company about 6 years ago, I've been advising various digital health companies, including one I'm very excited about, which is called Chronica. Chronica provides RPM in particular for independent practices, often immigrant physicians serving immigrant populations in rural and underserved areas. So I bring a little particular perspective around some of the challenges and opportunities around RPM, as well as the communication and coordination challenges too. So thanks for having me here, Asif and Jeff.
All right. And lastly, Asif Khan. I'm the CEO and co-founder of Huku.ai. Huku is short of two Latin words, hook, cure, meaning care anywhere. It's a transformative and revolutionary patient-centered communication solution that's built for post-acute care. And we continue to gain momentum in caring for helping care for tens of thousands of patients now, organized by hundreds or thousands of facilities and thousands of users. So glad to be here because we believe at Huku that the best way to provide proactive care is knowing what's going on with the person or with the patient. And the best way to accomplish that is through a remote patient monitoring program. So let's dive in and talk about the learning objectives. If you know what patient monitoring is or not, we'll talk about it really briefly. Jeff will give us a little overview. But what is really important is in this post-acute care outside of the hospital world, where patients are in their homes or in a skilled nursing facility or in an assisted living facility, they have a lot of people involved in the care, and the person who's responsible for providing or the provider group that's responsible for providing remote patient monitoring service to that patient, they may not be able to see the patient right away. So the care team or the family is involved, and we need to get to communicate quickly and effectively if there are things that are going on to provide better action. So at the end of the day, we believe responsive and real-time communication is at the crux of providing better proactive care. Um, then the second objective is really providing practical strategies to allow remote patient monitoring organizations to scale up. So most remote patient monitoring organizations, they can provide care to maybe 1,000 patients, but after that, the scale kind of becomes a challenge, and they are unable to scale beyond that. So we'll talk a little bit about that as well. So with that, let's just dive into some of those topics. So first is the role of responsive communication in RPM. So Jeff, a quick first, can you give the audience, because some of these audience members are, they may have remote patient monitoring. Many of them may not have remote patient monitoring, but they're thinking about it. Can you talk a little bit about what is remote patient monitoring and what steps, high level an organization can take to get started?
Sure. I think first, just a level set on what remote patient monitoring and RPM is. I think the main definition that people use is it's related to using some kind of connected device to capture physiological data. So something like blood pressure, blood glucose, weight, and then it needs to transmit that data directly to the care team. So what it's not, where I think sometimes there's some misunderstanding is, a patient typing in or reading into an app that then pipes it to a clinician. It needs to be the device taking that reading and then transmitting that data automatically. In terms of getting started and getting set up, I think the most important thing is to start with a plan. Every practice is different. Every patient population has unique needs and criteria. So I think starting with a plan is usually step one. That could include things like defining clearly what types of patients you want to serve, what any kind of alert or escalation protocols are going to be. So, for example, if you want people to get notified, if you have patients who you're monitoring who are at high risk of stroke, you want to send a notification above a certain blood pressure reading, that could go into that plan. And then I think it's important to define any roles and responsibilities and workflows related to that. The highest performing programs, I think, start out with clear goals and a clear plan in mind. And that again, that starts out with defining that patient population and the goals for them.
No, thanks, Jeff, for that. So let's dive in. I guess the first question is like, why does responsive communication matter in RPM? So maybe Tom, you can start out, and Jeff can share his perspective real quick.
Yeah, sure, absolutely. So one very nuts and bolts reason is that most reimbursement streams require a minimum amount of compliance by the patient in terms of measuring a certain number of readings per month, for example. And where there can be cases, whether it's a technical issue with the device, whether it's someone is elderly and perhaps has forgotten to take their reading, and not only can really harm the sort of the clinical purpose, or hold back the clinical purpose of RPM to try to get predictive and ahead of potential negative events that might cause hospitalization, for example. But it also has a direct bottom line impact on physicians' ability to get reimbursed. So really, there's a lot of both kind of vulnerability, but also opportunity to really get the communication streams reliable, real time, and actionable.
Great. Jeff, you want to add something to it?
Yeah, I think I would reiterate what Tom just said. I think if you look at the success outcomes for any kind of RPM program, whether that's the reimbursement level, the clinical outcomes, it's really a patient engagement and behavior change program at the end of the day that happens to use connected devices. And so the relationship that they have with your team really matters. And the quality of care that they think that they're getting, that they feel that they're getting, will impact how long they stay on the program. It'll impact whether they listen to what your team is asking them to do to modify their behavior. And that's what's going to impact those success factors, both clinical and financial.
Oh, that makes sense. So just to kind of get people a bit of context of what we're talking about, Jeff, maybe from your perspective, can you give out a quick, short example or a story where fast and timely communication prevented a bad outcome like a hospitalization or something bad event?
Yeah, there's been so many over the years, but I can think of a time, I think there was somebody who's being monitored for heart failure, and some troubling readings came into our team. Um, with heart failure, it's not always enough just to know based on the reading what you should do. It'll give you an indication, but
Right.
the next step is often to call and interact with the patient. I think one of our customers' nurses called the patient. They were having difficulty breathing. They couldn't sleep without being upright. These are all the signs that somebody's heart failure isn't being managed appropriately. So they were able to encourage the patient to go be seen by a physician, adjust their medications. I think the feedback was they thought they might have potentially saved that patient's life. Those types of stories happen so often, it's hard to even remember all of them. And it's often, that contact between the care team and the patient at the end of the day where a lot of the judgments made, but having access to that physiological data is often what allows them to know when they should be interacting with that patient. And it also sets some context around what might be going on with that patient.
Got it. No, thanks. I mean, I think this kind of gives a quick overview of what it is that we're talking about, so we can move to the next uh, po- section, which is like, okay, the impact of responsive communication on staff burnout and patient outcomes. So from that perspective, let's just talk about a couple of things. Like, when people think about implementing or they have implemented remote patient monitoring, one question always is that, what is the thresholds for alerts or versus noise, right? How do you tune the sensitivity so the nurses aren't overwhelmed, or the staff that's supporting so can you both, maybe Jeff, you want to take a stab at that, and then we can take Jeff's, sorry, Tom, can you take a stab at it and Jeff can add to it?
Yeah, so the term alert fatigue, is I think pretty well known, particularly those of us who have the wounds of using EHRs or building systems for EHR, electronic health records. Um, so in terms of like specific clinical thresholds and particular workflows like that, I may defer to Jeff, or other folks on the call here in the audience who know those details. What I can say is that um, the real bright future here, I think, really is AI. And like Jeff, I'm also pretty active in AI right now. And I think where it could really be a remedy, and you're starting to see this now when it comes to having truly intelligent alerts, is the fact that AI has the ability to have a very large, what's called context window, meaning that it could be a trigger that is based not just solely on, let's say, a very limited time window of, let's say, what happened with this patient in the last couple of days, right? But to basically look at the entire corpus of data around that patient, even including maybe social determinants of health information that you may have about that patient. And based on that totality, have a much better prediction as to whether or not this actually is a triggerable, if there's enough benefit to a trigger at this point than before, and having that done instantaneously. So I think where RPM solutions and as well as providers that adopt them will start to differentiate and start to gain outsized kind of advantage on both clinical and financial outcomes is leveraging that type of capability, sort of moving way beyond the term of alert fatigue, where it becomes alert delight. If I may put a trademark back next to that, maybe someone's already taken that, but literally make it where the alert is actually very, very, very helpful, as opposed to having any kind of significant risk that is annoying, which is unfortunately the status quo right now.
Yeah, Jeff, your perspective with anything?
Yeah, I guess, first I agree with Tom. I think alert fatigue is real and AI can do a lot to address it. I know somebody who is actually working on an alert fatigue AI platform for hospitals in the ICU, and the results that they've started to share have been pretty impressive. Um, in terms of managing it, in the interim period before AI can catch up, I think it's kind of a cop-out answer, but it depends, right? So the alert thresholds that you set for, a patient who's managing hypertension and is on the Mediterranean diet, and maybe they have, one or two medications, that's a lot different than somebody who has heart failure and is on GDMT. So, I think no matter what platform you're on, you want to make sure that the platform you choose is configurable to different types of patient populations, or at the very least, it's designed specifically for the patient population that you have in mind for your program. If you're choosing an RPM platform that's really designed for people who are managing stage 2 hypertension and you're managing those heart failure patients, you might not be getting alerted enough. And conversely, if you go the other way, you might get alert fatigue from getting alerted all the time for people that don't really need it. Um, so I think that configurability is, really one of the most key aspects there in terms of managing alerts. And then I think one other thing I'd like to point out, most programs have kind of an escalation among the care team too. So if you're a physician, you generally aren't getting that first line of alerts. That those would be the LPNs, MAs, RNs, whoever you have managing uh, that first line of patient care, generally there might be a threshold where, there's a certain type of alert or certain other symptoms. Once that care team has responded to the alert, they might escalate it to the overseeing physician. But, that's relatively rare. So, you can have human alert filters as well. You still don't want to be wearing out your care team, but, at the same time, these codes are time-based, and so that's what they're getting paid to do, literally as part of it. So, I wouldn't recommend filtering out the alerts too much for that frontline care team, is they can apply their judgment too. But it is important to have protocols in place so that they know when they should be responding and how.
Right, right. No, I think those points are valid. And just to add my own kind of Huku.ai plugin here real quick, I mean, and that's why we see a lot of remote patient monitoring technologies integrating or planning or working with Huku is because, you have this amazing remote patient monitoring technology like Continua or Chronica. Uh, but routing the notification to the right person based on whether it's a three shift operation or overnight or weekend, or escalating to your point for the front line first and then on to the other ones, and then so those are the things that in partnership with RPM companies, we are doing some great work on that front. Quick question, I guess, since we were talking about alerts versus noise, is there a metric out there that we can all track? But I know it's like it depends on your patient population, right? If you have higher acuity patients, then you probably have more alerts, to your point, right? If you have lower acuity patients, you probably have less alerts. But is there like are we coming to some place where there's like a concept of what should be the average alerts per patient per day? Is there anything like it? Like I'm just coming, it's probably too broad and you cannot put it in that little in that box because it's different. It really depends on your population.
Maybe within a certain population. So if it was, stage 2 hypertension or heart failure, there's going to be different alert thresholds that you would expect. But, I think part of it would also depend on other factors in that population, like the SDOH factors, how
True.
adherent they are to their medications and their care plan. There's a lot of variables that would come into place. So you'd need a pretty large sample size to be able to create something like that.
Got it. So talking about, I think in the with the perspective of staff burnout and better patient outcomes, if there's an organization that's really starting it out as a pilot or something like that, what is there like a method or some kind of equation they can use to staff their responsiveness to these patients' alerts appropriately and in the most cost-effective way? Is there like a approach people can take, like staff per number of patients or something, patients per staff? Is there something like that that can be looked at?
So I mean, what I've seen, you can kind of do some back of the envelope math, right? And you can think about how much time you want each person to be spending per month with the patient. There's about 520-minute increments in a month for somebody that's working full time. So if you wanted them to average 20 minutes per month and they were fully efficient, fully utilized, right? So they're not taking breaks or spending times in meetings or getting distracted by their phone, which we know all people do at least a little bit. There'd be 520-minute increments. In reality, I think most programs have probably around 200 to 300 patients per clinical staff. That's FTE. Once you account for efficiency, once you account for the fact that some patients are going to need more than 20 minutes, um, not everyone's going to get 20 minutes exactly right. Like some people will get 17, some people will get 27. But, that's kind of how you would back into something like that. And I think, in the low hundreds is a decent estimating point for like average level efficiency. I've seen some programs brag that they're doing like 1,000 patients per clinician. if they're billing for the full 20 minutes, it's not clear to me how that's mathematically possible. I would be skeptical of any program that's bragging about something like that because, at the end of the day, it's your practice that will be on the line with Medicare insurance if you get audited. And
Yeah,
those are the types of numbers that are underlying all of that, right? But, I think that's how you could start to think about it.
got it. Thank you. Let's move on to, since we talked a little bit about the staff optimization and burnout and how to address some of those types of things, let's move towards more like patient outcomes. So based on, obviously the remote patient monitoring, and if your communication is very real time with the right providers, and you're really taking care of, I guess, your patients more proactively based on the alerts. Uh, Tom, maybe you can, is there any clear significance towards like reduced hospitalization and ED visits?
So certainly, from my years in value-based care, those are kind of, some of the holy grail metrics. Um, of course, showing causality, can sometimes be a challenge in terms of trying to find the data to prove that any given remedy reduced the hospitalization. But there are increasing amount of studies around that are very positive in the case of RPM. From my experience and certainly Chronica's experience, is that one of the other types of patient outcomes, which is often overlooked but is actually quite important, are like soft outcomes, like relationship outcomes. Um, we've heard things from patients such as, um, "Wow, for the first time, I actually feel like my physician really cares about me." Okay, because of the not only having the device, but also getting the reach outs from the medical assistants, for example. And sometimes it actually becomes almost a social connection. um, and from a practice's perspective, you may be wondering, oh, that sounds like it could be very expensive, right? To spend too much time with someone on the phone. um, but turns out that there's a very significant financial case, which would probably be a subject of a whole other webinar, where for several hundred patients, let's say Jeff's example there, a practice could be able to have several $100,000 of free cash flow. Okay, and so as a result of that dynamic, as well as being able to really get higher patient satisfaction and relationship outcomes, which is a huge lever because patient loyalty to a practice is extremely high, both financial lever as well as obviously in terms of the morale of the staff, knowing that they have patients that just love being cared for by them. That is a very significant business and patient outcome. Um, but I think I'll just end with this, and it sort of relates to the previous question, is that when it comes to staffing and the whole model for how to structure and finance an RPM operation, um, a lot of the leading companies now is they basically provide a managed service. And Chronica is one of these because a lot of Chronica's customers are single independent um, physician practices. And so a managed service is where there is a financial arrangement. All right. And I don't want to use, I want to use the proper term for it. Okay. But it's loosely like a revenue share, but it's all legit. All right. It's all been vetted. But basically where it's the managed service that provides a lot of the ancillary clinicians, often medical assistants or NPs. And through things like virtual call center and otherwise, they augment the typically already understaffed practice so that the practice doesn't have to hire more people, train them up, and hopefully retain them. It becomes essentially the vendor's purview to figure that out as a managed service. So given that, the economics as well as structure and some of the things we talked about can be quite different under a managed service model as opposed to just licensing the technology, training your own staff or hiring your own staff. A lot of those approaches have, over the years have run into real problems in terms of financial sustainability, as well as shortcomings on the clinical outcome as opposed to a managed service.
Jeff?
Yeah, I think Tom has good points. At Optimize, we had managed services, and we also had the ability to allow people to design their own practice. And I think what I saw is if the organization had somebody that could really take responsibility for being like the manager of the program, at least half time, then the odds of being successful in-house were relatively high. If they didn't have that person, and that person is almost never a physician, by the way, physicians are too busy. If they didn't
Right.
have that person, then we would generally recommend the managed service because we could provide that level of management, kind of day-to-day accountability. Um, you could obviously still use a managed service even if you have that person who could do that. In that case, you could still get good results potentially. I think it just would depend on who you're working with. There are different levels of, I'd say, like effort and overall responsibility that I've seen among different vendors in the space. So just do your homework if you're looking to add a managed service partner is all I would say.
Got it. No,
Yeah.
thank you.
I think
Since we're
Chronic is a good example of a good company, but there's some that are out there that are more likely to probably encourage you to take more risk than you might know that you're signing up for. I'll
Got it.
just leave it.
No, that makes sense. So with that, let's just shift towards some best practices, in remote patient monitoring. Um, so do you can you share some ideas or practices that you have seen over the years where how do you make sure that you're not because when you have so much I think going back to alerts, like are there any best practices to simplify alerts so it's appropriate for the patient or the patient population that you're looking at, so it's not like over medicalization of the process, it's just like the right level. Is there a best practice on how to approach it?
You know, I think that the configurability is key. I would just go back to it really depends on your patient population, and you need to be able to adjust your alert parameters to that population, and then even ideally to the individual preferences of the patient, right? So if somebody tells you, I really don't like getting reminded to take my blood pressure every day at exactly 9 a.m. with the same, automated message, ideally that's not what's happening. But if it is, then you need to be able to turn it off, right? Because you don't want to be irritating or aggravating either patients or your staff if there's too much alerting. At the same time, the whole point of the program is to be able to get out in front of potential medical issues, medical emergencies. So you want to make sure that that's actually happening. I think one aspect of alerts that I'd say is ideal is like you want to be able to track the alert status. So it's one thing just to pop an alert. It's another to be able to track the status of what happens to that alert. So ideally
Right.
you're tracking, we viewed this alert, we're responding to it. It's either been dismissed because, in the case of our system, we can detect if the blood pressure cuff was used incorrectly and we'll surface a potential error, right? Blood pressure is a very finicky metric. There's a lot of issues that happen with people taking it incorrectly, or maybe they just walked up the stairs, they have their shirt on. Um, you need to be able to factor in for user error, those types of issues too. And then you want to track that alert through the pipeline to be able to show, we saw this alert, we reacted to it appropriately, and we believe that we managed the issue correctly based on the information that we had, right? It's not enough
Yeah,
just to what you don't want to do is have a dashboard that just pops 1,000 alerts with no context and no way to track what happened to that alert.
right. Yeah, no, I think you bring up a good point because I think a lot of the reimbursement codes are really tied to the readings, right? Like, I mean, there's that, but and then of course you gotta spend time with the patient and do what is necessary. But is there something in the policy side of things that's coming up to say, okay, how quickly you resolve this issue, or Because at the end of the day, that's kind of like what is the most important thing is that like how responsive and how quickly you resolved an issue. Is there something like that that's tied to reimbursement, or currently it's just more passive and just part of the process?
So I think the good news from a regulatory side is that there is a lot of tailwind and bipartisan support for RPM. By way of example, the American Medical Association, which creates the CPT codes that underlie CMS billing, they recently just came out with new codes that actually uh, uh, prescribe RPM for certain clinical conditions where you don't have to have um, a minimum of 16 readings per month, right? Much fewer readings, but still be able to get reimbursed. So I think generally, with regards to the response time being something that is ensconced in policy, I know I know less about that, but I think generally now is a very interesting and I think favorable time to look at what RPM could mean for your practice. Okay, because the finance side is there. I want to kind of link to this, just the concept of responsive communication in another way, which is that the more that an RPM system can avoid having to change or force change on the communication paths and workflows of the physician as they are status quo, generally you're going to be a lot more successful. So, for example, in the case of Chronica, they have their own MAs, medical assistants, as part of the managed service. And these medical assistants will contact those physicians however those physicians want to get contacted, whether it's by pager, whether it's by whatever mechanisms, email, if it's Huku, right? You can use Huku, rather than imposing upon the clinician and also try to avoid with the staff as well. Here's another thing you got to learn because they're already getting pummeled with way too many messages already. I mean, the EHR inbox itself is already a disaster, right? And so then it goes back to, well, do you have an economic, a financing model that could support a human or maybe in the future an AI agent to do this kind of smart, highly ultra customized communication, whether it's for learning or day to day? And what I'm here to say is that with RPM and even putting aside AI, which only makes it better, the RPM financing model, it does support staffing, whether in-house or outsourced staffing models, where you can have that level of kind of, you don't have to go in and rip and replace and redesign a whole bunch of workflows. You'll have to do some, but nothing like to the extent it was maybe even a couple of years ago, as opposed to now.
Yeah, no, no, thanks for that. I think that elaborative explanation of I think how to kind of go about it. One of the other, I think, best practices that a lot of organizations think about is like starting RPM is, we're talking about patients that are really sick, could be, right? And something bad happens, who is kind of responsible, right? So can you guys maybe Jeff, you start like what like is it the device? Because if the device didn't kick out the alert and something bad happens to the patient, then is it the device maker, or is it the platform that got the alert or didn't get the alert, or is it the nurse that's looking at it, or they didn't escalate it to the right provider? How does it go? I mean, who's responsible for this? I think that lots of people think of this as a big liability and they approach it in so many different ways. What are some of the best practices on how to approach that to protect you? You're trying to do the right thing, provide care, but bad things can happen for various reasons.
Yeah, look, I think everyone has some level of responsibility, right? The device manufacturer is responsible to make sure that the device works as it's supposed to and transmits the readings. Whoever is in charge of reviewing the readings and alerts is responsible for making sure that they get responded to, right? Whether that's an in-house person or a managed services company that's handling that for you. Um, and the provider ultimately is responsible for making sure that the billing is accurate, right? And a lot of the better software companies help to automate that and make sure that there's compliance around that, right? Because ultimately the billing submitted through the provider's NPI And if anyone gets audited, it's generally going to be the provider. Um, so, I think it's important to know what those different responsibilities are and to have them outlined, clearly from the get-go, in writing, and ideally in a contract to make it clear. But,
Got it.
it's something that uh, it's a serious type of program. Everyone who is doing it needs to take it seriously, but it's also something that's been de-risked and kind of proven to work at scale at this point. So it's not like if you decide to do RPM, you're the first person doing it for the first time ever.
True.
There's been, I think, over 1 million patients just on Medicare at this point that have done an RPM program.
Got it. Got it. All right. So last question before we go to our lightning round, which will have some rapid fire questions for you. So last question, like if you're looking to implement an RPM solution, right? Like anybody on the call, what is it that they should look for, in an RPM? I mean, yeah, I mean, it could have 10,000 things, but what are some of the main components? And I think Jeff, you thanks, and Tom, you also alluded to some, ability to configure it based on the types of patients and some of those types of things, and the routing and escalation kind of notification, which something Huku is really good at doing. Can you talk a little bit about like what to look for in an RPM solution if people are looking for?
So I maybe I'll venture. I have a little bias because I'm here, representing Prodigal, but I think some of the things that we've seen are first off, um, you know, how 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 much is how much does one feel that that a particular vendor can really be trusted? Okay, and I don't mean
True.
that in a nefarious way. I mean trusted in terms of being able to be on top of the details, many of which we have discussed here. So one example of that is, for example, in the case of Chronica, a lot of the patient populations are not English speaking. A lot of them are Spanish populations, and even the physician may even speak like a third language, a different language. And so being able to do things like, okay, we will hire and manage and train MAs that speak the native language of your population. All right, that's been one huge learning in terms of being willing to do something like that and being able to have an economic model that actually enables that has been a very helpful advantage, I think, for a company like Chronica with respect to other RPM solutions. And they have a very pretty narrow focus in terms of who they're going after. And I'll just say the other part is one way to understand, okay, how good is the technology platform, particularly the cloud platform, separate from the devices, but well integrated with the devices. How well is that system actually designed? One of the real proxies for that is, well, if it's a managed service, that means that the vendor has their own clinical staff that have to use that platform. Does it appear that those clinicians are happy with their platform that their own colleagues built? And is it actually making them more efficient? And what are some specific examples of that? And so just one, without plugging Chronica too much here, but just one really cool example of that is that the Chronicle platform has some AI capability built into it where it will suggest to the MA what are the most ideal times to call a particular patient based on an AI analysis of all of the past call behavior and the habits and the call length and everything, so that it not only saves the MA time to actually have a higher probability of getting the other person on the line, but also at the right time in terms of the patient's daily routine that has proved out to be a more opportune time to have a conversation about RPM. And so those are things where if you have an opportunity to kind of talk to the clinical staff that you may be outsourcing to about, hey, what's your favorite thing about your platform? Every platform is imperfect. What would you change about it? That could be very telling. And that one particular feature is something that has gotten major kudos, from the internal clinical staff, of a company like Chronica. So I would say basically it's trust, and relationships, and how well does their platform actually work in concert with humans as opposed to at odds with staff are two key things to look for.
No, that makes sense. Jeff, on your perspective?
Yeah, I think I would start out by making some goals for your program in terms of what you want to get out of it, and then kind of make a checklist from there. I think having software that has workflow support for everything that you want to do is important. Um, I'm also biased, but I think if something integrates with some really nice and proven communication software like Huku, that's generally going to be better than some text message feature or something that an RPM company kind of built into their own platform as an afterthought, right? So I think having that communication really thought through and ideally connected through something like that is going to be generally better than a more homegrown solution. And then, I do think that trust is an important part of it. I think you ideally want to be interacting with somebody who has done this before, who knows what it's like to design a successful RPM program. You want to know that you can continue to talk to that person and they're not just going to sell you a project and throw you over to some customer support person that doesn't know what they're doing, frankly. And part of that might be looking at the company profile, right? Like RPM's gotten bigger. There's a number of companies that are private equity backed. I don't know if the clinical results for all of the different private, bigger private equity backed companies are there, even though in my opinion they should be publishing more clinical results if you've been in business for 5+ years. Um, they have different goals sometimes. So, sometimes it might be better, frankly, to go with a smaller program where you're going to get attention from experts versus like getting kind of thrown into a machine that's just designed to turn out revenue. Because, at the end of the day, it's your patients. You want to maintain strong relationships with them, and RPM can help you do that. And you want to make sure that it's not harming those relationships in any way. So I think choosing a vendor that you trust is probably the most important thing.
Yeah, no, I think that's a really good point. And I think the key thing that you mentioned, Jeff, earlier is that you have to create your own goals first. Like, yeah, we gotta drive revenue, but what are the things that we want to accomplish with this program? And then kind of go out and look for a solution. And so thank you so much, both of you.
Yeah.
So let's jump into our lightning round quick questions. They're not too many, just like couple. So, you both can answer if you like, or one can answer, but somebody has to answer. So, what is one non-negotiable item for responsive RPM? Something that's
I think multi-channel communication, so the ability to communicate with patients through ideally multiple methods like phone, text, a secure communication app. Different people have different communication preferences, and at the end of the day, if you're not able to reach them, you're probably not impacting their behavior very much. So I think that would be a non-negotiable for me.
got it. What is the single best metric to prove that RPM is working?
I'll take a crack at that. I think just hard edged is uh, lower escalation times and also lower percentage of interventions that are missed can be a pretty clear cut way to not only show ROI but also to avoid patient harm. So that's probably the one I would pick.
All right. Okay, last question. What is one tech or policy that you would either ban or introduce tomorrow to improve RPM safety?
I mean, I think honestly, enforcing the policies that have been set might be enough. There's been, kind of rumblings in the industry of certain companies maybe not being completely compliant, and OIG's made announcements that they're looking into companies and issues, but I haven't seen any big announcements about anything happening yet. So, I think um, there's been a lot of thought that's gone into the policies that have already been created, and I think some public enforcement would probably be enough to keep things straight.
Got it. Got it. All right, cool. So we have a couple of questions from the audience. Let's just ask, if you could change one policy or product feature to improve outcomes in 6 months, what would it be? If you could change one policy or product feature to improve outcomes, so it's really connected to patient well-being in to improve outcomes in 6 months, what would it be?
If it were a class of product features, it's the two magic letters AI, I think.
Oh, right.
But AI, it's not AI, right? And I think that whether it's some of Huku's existing capabilities, as a foundation, I understand there's a lot of members of the audience who are already very satisfied Huku customers. I think it's a great foundation that makes adopting something like RPM so much easier if you already have that fabric of communication that's powered by a platform like Huku. But I think that to kind of go to that next level is being able to have whether it is AI agents or some kind of AI intelligence, be able to even more rapidly and more comprehensively assess like the current clinical situation, of both in terms of, hey, the availability of clinicians, are they available to be escalated to, right? And obviously what's going on with the patient, maybe even intel about the caregivers, and to have essentially a more and more robust AI modules rather than individual kind of point solutions that can come in and really solve a bunch of problems at the same time, that relieve the fact that we've got such a big healthcare worker shortage now, that we need technology like RPM to be implemented, in probably a different way than a lot of digital health solutions have in the past, but also knowing that there is a great financial model behind it too, right? Which is not necessarily so hard to find in healthcare.
No, great point. Another question here is, what is one practical change a provider can implement this week to make RPM communication more responsive? So something that's simple, I guess. The person asking is something that's simple enough to be implemented quickly, but will improve make the RPM communication more responsive. I think you already alluded to some of those points, Jeff, but maybe kind of whatever comes to your mind.
Yeah, I mean, a week is quick, right? But if they've already got RPM in place and they could deploy something like Huku, right? I think that would be um, a good starting point. But I think just looking at adding to your communication stack, maybe looking at your internal kind of workflows and how your internal team's responding to alerts and different issues, and just making sure that all of that's aligned with what you think is going to provide the best outcomes.
No, that makes sense. All right. There aren't any additional questions. I will give maybe another few moments. If anybody has any questions, they can ask now. But in the meantime, thank you so much, Jeff and Tom, for joining us. And I think this was a really short and sweet, quick, session that'll help our audience on how to go about or how to look at different ways to improve if they are doing RPM already or if they plan to implement it. I think this is a really great session so people can kind of get their minds around it, and they can reach out to let's see, us if anybody has any questions at huku.ai, or on our website, I guess. I think you can type in support@huku.ai and we can help connect with the right people. So with that, thank you so much. Everybody have a great day and the rest of the week. Thank you so much.